Hi there. My name is Matt Glasgow. I'm a senior at Bates College and an undergraduate intern at FSIE. there, there are no disclosures in this study. So objective diagnosis of GERD preoperatively is necessary or is crucial to good anti-reflux surgical outcome. The gold standard for making that objective diagnosis is ambulatory pH monitoring off medications. Prior scholarship outlines that the ideal GERD anti-reflux surgery candidate is a patient with a good response to PPI medications, an elevated esophageal acid exposure as detected by off-medication pH testing, and typical GERD symptoms. However, pH testing is limited in detecting weakly and non-acidic reflux events, which have been postulated to contribute to persisting symptoms. And as a result, impedance testing is being used in the clinical setting at increasing rates. However, impedance testing, which detects total reflux events regardless of acidity, has several limitations in of itself. First of all, normal values may differ for on and off PPI testing and by population and diet during the testing. Second, we have shown that while on PPI medications, the commonly used value of 48 reflux events as the threshold of abnormal does not correlate reliably with pH testing off medications. Therefore, the role of impedance testing for selecting patients for anti-reflux surgery remains unclear. As such, the aim of this study was to assess outcomes in patients that underwent anti-reflux surgery based on an isolated abnormal impedance test compared to those that had both increased esophageal acid exposure and an abnormal impedance test. In order to do so, we did a retrospective chart review of patients referred to the Oregon Clinic for management of GERD-like symptoms between 2012 and 2017. Abnormal patients were included if they had an abnormal impedance test based on a normal value of 48, total reflux events, off medications, and underwent anti-reflux surgery. Patients were excluded from the study if they underwent surgery for a paraesophageal hernia, underwent a redo surgery, or failed to complete the 1-year post-op symptom questionnaire. The data we collected included preoperative symptom frequency scores for a variety of GERD symptoms, where 4 correlated with daily and continuous, and 0 correlated with rarely/never. Other data that we collected included primary preoperative symptoms, impedance pH results, and a postoperative symptom questionnaire, which included the same measures as the preoperative clinical symptom assessment. Symptom resolution was self-reported by patients, where 5 corresponded with complete resolution and 1 corresponded with not resolved at all. Percent symptom-free for each group for individual symptoms was calculated by dichotomizing the symptom frequency score described earlier based on a value of 1, which corresponded with a monthly experience of that symptom. In other words, patients were considered symptom-free if they had the symptom less than monthly or less than monthly, rather. In order to compare these two groups, we used a Mann-Whitney U test, one-tailed t-test, or a chi-square contingency test, depending on the variable. The 576 patients underwent anti-reflux surgery or underwent impedance pH testing in that 5-year period. 115 of those patients had an abnormal impedance and underwent anti-reflux surgery. 82 of those 115 patients answered the postoperative symptom questionnaire. That final cohort was divided into the pH minus group, or the normal pH group, and the pH plus group, or the elevated esophageal acid exposure group. There were 44 in the pH plus group and 38 in the pH minus group. There were no significant differences in gender, age, or BMI between the two groups, and symptoms included typical GERD symptoms like regurgitation, heartburn, dysphagia, and some extraesophageal symptoms. The pH minus group reported a significantly lower symptom resolution than the pH plus group. As you can see here, a majority of patients in both groups experienced typical GERD-like symptoms, and a minority of those patients experienced atypical symptoms. So, as you can see here, both groups experienced significant resolution of both regurgitation and heartburn. However, you can see a distinction between the level of resolution between the two groups. However, with dysphagia, the pH plus group experienced significant resolution, while the pH minus group actually got worse, which is interesting in the context that dysphagia is linked to acidic reflux, and the pH minus group did not have objectively confirmed acidic reflux. Now, looking at the percent symptom-free between the both groups, you can see that the pH minus group had significantly less patients that were free of heartburn, and only slightly less patients that were free of regurgitation. We hypothesized that if the preoperative indication was hiatal hernia or regurgitation, then the likelihood of a successful outcome would be higher. However, preoperative regurgitation or hiatal hernia did not increase the likelihood of a successful outcome. So in conclusion, abnormal pH testing remains the best predictor of a successful anti-reflux surgery. However, isolated abnormal impedance off medications may be an adequate indication for anti-reflux surgery in highly selected patients. Further, we found that GERD symptoms significantly improved in the abnormal impedance alone group, but not as much as the abnormal acid group. So we weren't able to find reliable predictors of successful outcome in the abnormal impedance group alone, and therefore operating based on impedance alone should be done with extreme caution. Thank you.